Welcome back to another episode of CRC Health Connect. I'm your host, Dr. Siu-Him Chen. We're very exciting to have Dr. Amlani back with us today to talk about something quite important. Good morning, Dr. Amlani.
Good morning. Thanks for having me back.
So today's topic is a hot topic because, as we know, cardiometabolic and inflammatory diseases are extremely popular and trendy today. Today's topic is a disease known as a disease of the affluent back in the day, because of a better protein intake, better nutrition often become a risk factor. So we're going to talk about gout today. Dr. Amlani, what exactly is gout?
So gout is a very painful crystal type of arthritis. So what happens is you have uric acid crystals that precipitate out of your blood and deposit in your joints and tissues. And when that happens, you have an immune system which attacks those crystals because they're foreign body, and creates a very potent inflammatory cycle which causes a lot of pain. So typically it happens in joints and tissues that are farthest from the heart, because that's where the temperature is coldest, and that encourages precipitation of the gouty crystals out of the blood.
So why exactly is it known as a disease that is more prevalent among the affluent?
Yeah, I think it's because there's the affluent tend to eat a certain way. Like they tend to have a certain dietary pattern, which consists of a lot of meats, a lot of shellfish, a lot of sugary and alcoholic drinks, and those are all risk factors for gout. So the dietary part of it makes them more prone to having gouty attacks.
Mm-hmm. So you mentioned protein and alcohol. What are the other risk factors for gout?
So there's a lot. Typically, gout you see in older people, more classically in males, but females can also get gout as well. People that are dehydrated, excess alcohol, which we already discussed, meats, seafoods, fructose, so energy drinks, sodas, pops, those kinds of things. And then also people that are post-surgery and that are on diuretic medications, and then people that have had injuries to their joints as well. The last big one I think would be chronic kidney disease, because it's harder to eliminate the gouty crystals from your blood. So there's a lot of risk factors that exist for gout, and they're all very common among the population.
Wow. So how do these patients usually present?
So typically, a gout patient will come in and say that they've had a really, really red, hot, painful, swollen joint, and the most classic place to get it is in your big toe. Again, because that's farther from the heart, but you can get it really in almost any joint, from your toes, ankles, fingers, wrists, all the way up to your shoulders, elbows. You know, I've even seen gout in the spine one time. It's that's not very common, but typically it's an intermittent pattern of a red hot swollen joint. And then if you have gout for long enough, it can become a more chronic pattern where you just have chronically swollen and painful and damaged joints. But the classic presentation is a really red hot painful swollen joint that tends to self-resolve over a few days to a week.
I see. So when these patients come to the clinic and see you, what kind of history or signs would there be present? You mentioned some of them already.
Yeah, so typically the things that we would look for would be all those risk factors that we talked about already, because that would point us more towards a diagnosis of gout. They may present with, like I said, a red hot swollen joint if they're in an acute flare of gout, but sometimes they don't present with anything because they've had the flare and it's resolved, and they're coming to me to see how to prevent more flares like that happening in the future. If they have had gout for a little bit longer, and they have more gout in their blood, like more uric acid in their blood, sometimes they can get these little whitish yellow deposits on their skin as well. Those are called tophi, and when we see those, then the diagnosis of gout becomes much more likely. We see those all over the place. Toes, fingers, extensor surfaces like elbows and knees. But a very sneaky spot for tophi to hide is actually on the tip of the ear. So we'll also go looking there as well.
Oh, interesting. So if there's a high suspicion for gout, are there any diagnostic tests or lab work that you send the patient for?
Yeah. So like any patient, we'll do the history and physical, and then we'll send them off for investigations unless we're 100% sure that it's gout off the bat. But typically, we'll get blood work that includes a uric acid level, because if it's high, that points us more towards a diagnosis of gout. The sneaky part about the uric acid level, though, is if you test it during a flare, it can be falsely low because the gout is not in the blood, it's all in the tissues at that time. So you actually have to test the uric acid level outside of a flare to get an accurate reading. We'll also test your kidneys because, of course, that's a risk factor for gout as well. And then we'll do X-rays or other imaging. On X-rays, you'll typically see like little rat bite erosions on the bones where gout has been. There's also more specialized imaging. There's an image called a dual energy CT scan, which sometimes we send people for, and it can actually see crystal deposition in tissues as well. And then the last thing we might do actually is take a sample of the fluid from the joint and send it to the lab, because sometimes we can see crystals in the fluid itself, and that would point us towards a diagnosis as well.
I see. So in terms of making a diagnosis, do you see other conditions that can like look like gout, but turns out to be just a mimicker and not the real thing? And how do we tell them apart?
Oh yeah, it's very tough sometimes. The biggest one I would say is infection. So someone that comes in with, for example, a hot and swollen knee. If it's just one knee and it's just one joint, then the first thing that you actually have to think about is an infection. Oftentimes, what will happen is you'll take a sample of the fluid to see if there's an infection in the joint, and there is no infection, and so actually gout is mimicking an infection at that stage. But there's lots of other conditions that can look like gout, but not actually be gout. There's a condition called pseudo gout, which is actually calcium deposition, calcium crystal deposition, as opposed to gout deposition. So it's just a different kind of crystal. There's another one. There's another type of crystal that you see in young women as well. That's not gout and not calcium, but it's actually called it's like a hydroxyapatite crystal. So different other crystals can look like gout. And then there's also other conditions like rheumatoid arthritis that can sometimes be very hot and very painful, swollen joints, and they can look similar. So when a patient comes in with a question of gout, our mind is always thinking of other things, and we have a wide differential until we confirm the diagnosis.
Wow. So I guess when in doubt, just send a referral over to check it over. In terms of that, so if a referring physician or nurse practitioner per se is suspecting the patient to be having gout, what kind of sort of preliminary investigations or whatnot would you prefer when the referral arrives at your desk?
It's a great question. I would encourage anyone that has a patient that they think might be gout, of course, to do a history and a physical, and see if they also agree that this patient has gout. From a preliminary investigation standpoint, basic blood work. So looking at their cell counts, their differential, and their kidney and liver function, as well as an inflammatory marker like a CRP, can sometimes be very helpful. Often in gout, the CRP or the inflammatory markers are extremely high, and that can also be seen in infection. So sometimes that makes it tough to tease apart, but it's helpful for us. And then any image, honestly, like an X-ray would be just fine of the joint that's affected, so that we can take a look and see if we see any of those signs on the X-ray to point us towards a diagnosis.
Okay. So if the diagnosis is made, then what are the sort of the first steps into helping this patient?
So there's lots of things that we talk to people about for gout. We'll always talk about lifestyle changes. So decreasing alcohol in their diet, trying to push them more towards a vegetarian diet, away from organ meats, away from energy drinks, away from shellfish if we can, and I think I mentioned alcohol already, but decreasing alcohol, and then making sure that they stay hydrated as well is a really big thing, because dehydration, like I said before, is a risk factor. And then what we'll do is we'll deal with the acute flare of gout. and then decide if they need anything in the more longer term to manage their gout levels to prevent flares in the future. So we may start with a medication called colchicine to deal with the acute flare of the gout. Sometimes if people can't have colchicine for various reasons, then we'll try a little bit of prednisone or a little bit of steroid, and that can be given by mouth or by intramuscular injection or into the joint itself. So those are probably the two more common things that we might use. People have used things like indomethacin or Advil or naproxen, but oftentimes the people that have gout have a good reason not to take those medications because they have high blood pressure, they have kidney disease or whatever. So I tend to shy away from those. I tend to use more colchicine and prednisone. So that's dealing with the acute flare of gout, and then in the long term, there are certain reasons that people may need medications to control their gout in the long term to prevent flares. And so we would talk about that. If they have any of those reasons, and we would put them on a medication, most commonly something called allopurinol. But if there's a reason not to put them on allopurinol, for example, if they have a gene that predisposes them to side effects from that, we might put them on something else, such as Uloric. But really, if you look at gout management, there's lifestyle stuff, there's dealing with the acute flare right in front of you, and then there's preventing gout down the line.
Right. So I remember when I was writing my exams back in the day, there was some controversy or some concerns about febuxostat for in terms of cardiovascular safety in the treatment of gout. Can you comment a bit on that?
Yeah, so that was from a trial before that was brought up, and there was some concern about that before, but that has since been actually thought to be not true. So there is more evidence out there now that is showing that febuxostat is actually not dangerous from a cardiovascular perspective. And actually, if you think about it, uncontrolled gout itself is a systemic disease, right? And there's evidence now that shows that gout actually predisposes you to cardiovascular complications and cardiovascular disease, as you would know as well. So I would argue that actually treating your gout is actually better from a cardiovascular perspective, even if it is with Uloric, than leaving your gout uncontrolled. So I don't tend to shy away from using Uloric in cardiovascular patients. But again, my first choice usually is still allopurinol for everyone.
Great, thanks for that. So in terms of the prognosis, sort of long-term management of gout in your patients, do they enjoy pretty much a standard normal quality of life when the gout is treated, and how often do they usually have flare-ups, and what's the outlook on that in general?
Yeah, that's a really good question. I always tell people that my goal for them is for them to forget that they ever had gout in the first place, because if gout is done right, there's a pretty good success rate in terms of treating the gout, both from my experience as well as my colleagues' experience as well. But it is a little bit onerous at the beginning. Like, you start on 2 different medications and you're doing blood work fairly often until we get things under control. So if patients put the work up front, not only from a medication standpoint and a monitoring standpoint, but from a lifestyle standpoint as well, I'm usually very optimistic that their gout would be that their gout would be in control for a very long time. Even on the medications, there is a chance that you can get a flare if you have a bunch of alcohol or if you have a bunch of meat. But if people are diligent about their lifestyle stuff and they're diligent about their medications, they often do quite well.
Great. Wow, that's good to know. That's good to know. Well, Dr. Amlani, thanks so much for your time to educate us on gout. We would love to have you back in the future. As you mentioned, gout is an inflammatory disease, and there's so much crosstalk between cardiovascular health and inflammatory processes and rheumatology these days. So that's a really trendy topic. So we'd love to have you back in future episodes to discuss that.
Thank you so much. Yes, I'd be happy to be back.
Thanks again. Have a great day.
Take care.